like to start with is maybe if the panel could each tell us an example of what you think is a good example of research being operationalised into practice in the AOD field. So something that you thought might have worked well, how did it work? And I'm going to put Dan on the spot to start with.
Yeah, so I think for me, I mean, one of the advantages that, I have working at Turning Point is that we have this integration between, really great integration between research and clinical practice. So what that allows us to do is when we're thinking about identifying a gap in practice, we can spend time with our clinicians talking about where the gaps are. So a really good example would be work we've been doing on our helplines around trying to understand people. So the issue was that we have people calling the helpline. Government has a very linear view of treatment. So somebody rings the helpline, we provide a service, they go to the service, they get help, all fixed. That's the sort of way government thinks around the treatment journey. But what happens is, of the people who ring our helpline, probably about a third of people actually want to get help. And only about probably 50% of them actually end up at a service. So we have this huge gap between the struggle for people to put their hands up and ask for help, and then actually being able to offer something to that huge amount of people, who will put their hands up for help but don't actually want to go to face-to-face service. So we work with our clinicians to think about what a telephone-based intervention would be. And so we did lots of consultations and looking at the elements we put in place. And so we developed this program called Ready to Change, which is a 6-session telephone-based intervention. And so we trialed it in the helpline as a sort of assertive follow-up service. And then I suppose what we've done then is retrospectively sort of gone and done the clinical trials on it. So we then, from there, after developing it, went to NHMRC and got funding to test the intervention, and fortunately showing that it was successful. So it would have been really embarrassing if it wasn't successful after having established it. So I think the key thing for me is people at the coalface sort of understand what the gaps are, and we really need to think about, for successful research into practice, we need to really think about how researchers and clinicians have the opportunity to dialogue around where the key gaps are. And then to really think about, when we talk about co-design, not just involving consumers, but making sure clinicians are actually there to sort of help us think about how to implement that in practice. And I think that's the key challenge for us that work in the research in the clinical space is, we're all very busy, we're all distracted with our own sort of various agendas. How do we get in the room and sort of help each other identify where the sort of low-hanging fruit is and where we can see where we can improve our practice.
Great, thanks, Dan. So we've met our other panelists today, but we haven't met Tim yet. So Tim, I'm going to get you to start by just giving us a 1 or 2 sentence spiel about who you are and why you're on stage. And then maybe if you could tell us a bit about your example of something that you think has worked well.
Sure, thanks guys. So hi everyone, good afternoon, sorry I'm a bit late. I'm a lecturer over at Darwin University, so I do in psychology, in fact, but most of my stuff is around addiction and harm reduction, a little bit in corrections as well. I think that'll do. In terms of, I guess, stemming off what Dan said, I mean, I think there is a large provisional gap between the end consumer research and practice, unfortunately. And I guess speaking from my experience personally, I originally started doing a lot of stuff with people who inject performance and image enhancing drugs or steroids. And you wouldn't traditionally consider these people substance abusers, but I assure you they are. And they're an important part of or should be an important part of those harm reduction frameworks. So in terms of, I guess, translating research and practice and integrating everything in that respect, in Queensland particularly, I did a lot of work there from the consumer end. So in terms of finding out where these people were coming into contact with AOD services, happened to be needle exchanges primarily. And so I made industry partnerships with particular NSPs and harm reduction services that way. And so through an organic sort of process, we obviously integrated, what were the needs, what were the gaps, what was going on, and started to pitch things at, I guess, a point that was most appropriate for the consumer themselves. Okay, and I think that's really where the heart of all of this translational sort of stuff should be, trying to integrate what people's needs are, what we can provide them with, and also what the evidence-based practice informs us in terms of treatment, intervention, things like that. And so particularly with PED users or steroid users at least, we've gone on with Queensland Injectors Health Network to provide some safe injecting resources, to redistribute some online resources, facilitate live discussions, and sort of tackle things from a peer-led perspective, because that's what they wanted. And of course, these harm reduction services, as you all know, are really, want to provide as much support as possible. And I think that's important. It's important to build trust and rapport first before you even start to think about treatment and intervention. Won't bang on about it too much more.
Well, thanks, Tim. And Chris, do you have any examples kind of spring to mind for you?
Yeah, so as I think about this question, I think, so this is how it should be done, this is how it's done. It is really, and the main difference, although, so the main difference in sort of, a small tertiary referral service in the NT, so the sort of service I work in, it is really small. So, and the interest of the clinician involved is the key issue, and the time sort of factor. So, Dan, you're set up with this where you can really, you're at the coalface, you can ask the clinical question, and you've got somewhere where you can deliver the clinical question and get a really clear outcome with clinician input, because that's, I think, just so key for research for me. You can tell when it's been driven by clinicians, because the right questions, or at least the useful questions, are being asked, addressed and answered. So, that sort of model is marvellous. The clinician's asking the questions and you give it to the research team and they can do the work in the clinical space and feed it back into clinicians. It's just perfect and fantastic. And really, a great sort of setup. In the NT, of course, then it's hard. It's a smaller kind of service. We're quite siloed. My interest in research, or my skills in research, they're not great. So that will flow on for the rest of the, in terms of how the whole service runs and works. But I was thinking, where it does work, well, for example, the depot, so opiate pharmacotherapy program, and the new introduction of depot buprenorphine. Now that isn't widely done throughout Australia yet. It's a fantastic product. There's a really good evidence base for it. It's an absolute sitter, so it's very low-hanging fruit for the introduction of a good, solid, evidence-based thing. For those of you who don't know, that's just, it's a once-a-month injection of depot buprenorphine for patients with an opioid dependence, and it really has great outcomes. Helps keep people in treatment. It's certainly probably the biggest thing. It's very acceptable for patients themselves. They don't have to dose at pharmacy each day, and it's a great treatment. It's really good. It definitely saves lives. So, and we could introduce that without too much trouble up here, and we've got that now, and probably about a quarter of our OPP patients so far have transitioned onto the depot, and we'll just keep pushing that and expanding that. We've got a take-home naloxone project too, just to get our overdose prevention, overdose training, so we can do those sort of things. But there's a lot of space that it's just not. It's slow and hard to kind of introduce change. Yep.
Yeah, cool. Thank you. So we know that services, they want to do work that's really effective, they want to serve their clients, and they want it to be evidence-based. But how do we know which evidence is appropriate to be included into our practice? So I might throw to you, Dan, on this one.
It's a great question, Kath. So what does evidence-based practice mean, and how do we do it? And I think, I think we did a piece of work for the Victorian government, which was around sort of a big service planning document around looking at sort of how you commission services, sort of how we think about sort of identifying different levels of need and how we nuance treatment at different levels. And part of that research was just looking at the evidence of what works. And I think, what's really great in the space is there's lots of really great evidence about what works. the challenge is, as you say, how do we equip clinicians on the front line with that evidence base? And I think that's something that I would say the peaks are in a great position to do. I mean, I think across all the states and territories, there's some great, fantastic research. I mean, Australia kicks above its weight in terms of research in the addiction space. It's sort of one of the world leaders. There is a fantastic evidence base. And I think the question is how do we actually disseminate that in a way that's meaningful for clinicians? Certainly, in terms of sort of professional programs, there's a whole range of graduate certificate and master's programs in addiction that sort of disseminate that evidence base. We want one of those, for example, through Monash, and I think it gives people a really great overview of the literature. But I think, it'd be great to think about how we can support the peaks AADANT to sort of, to be sort of a clearinghouse for knowing where that information is. So I would say the first port of call is to give Peter a ring, ask him sort of, do we have an evidence on that? And I think it's about that. I think that's a really important role for the peaks around, because collectively across the country, there's a lot of knowledge and lots of expertise. And I think one of the things we need to stop doing is sort of duplicating everything. It's, multiple times across different jurisdictions at the federal level. There is an enormous amount of literature out there. And I think it's about how do we bring that together and how do we make it easy for people to access? And I think the other thing is, and the other thing that I suppose my ask is for in terms of if we can get investment in, is I've certainly seen people sort of, we did this big piece of work for the federal government around designing a quality framework for national service, across all alcohol and drug services. And I think we went and spoke to every single service in the country that was funded through the NGO GTP round. And what was evident is some people, were doing evidence-based practice, but what they'd done is they'd seen somebody present at a conference, they'd taken that work and they'd implemented it into their workplace without any sort of supervision or support. So they were hungry to implement evidence-based practice, but they were doing it without, the level of support they actually need to nuance that to their sort of local sort of needs. And I think that's what we need. We need not just the evidence base of what works, but we actually need to be able to support agencies to have some consultation around how they can adapt that work to their local setting and what sort of fidelity and other types of supports they can put in place to make sure that they can deliver it in a way that's in line with the evidence.
I guess I've got a comment in that certainly working for NT Health, like I am not a free agent. I'm not able to speak often. I'm not able, any data I collect is not mine. It belongs to NT Health. And they have a very, definitely at times, that data is not welcome. And I'm not allowed to submit for publication. I'm not allowed to discuss it. That has happened, and that happens all across. I'm sure that happens interstate as well. So it's not simply, I know you're not saying it's simple, but you can't. A piece of evidence collected on the ground in the clinical space belongs to the Department of Health, and they can tell you whether you can publish or not, or whether you can even discuss it more broadly or not. So I think we can't be naive about that, and also, and including even broader discussions, presentations to Parliament, these submissions things, these are actually quite tightly controlled. And so perhaps that's, you can have a really good idea. I would, even just thinking about the managed alcohol, a managed alcohol program, like that sounds good. You can get all the evidence base in the world and it will not get off the ground or will not able to be discussed or will have because of the strong political overlay of the context. So I keep looking at Peter, but I think that perhaps that's the role of the peak bodies as well, to be able to kind of give a voice sometimes when we clearly cannot within the Department of Health. That's interesting.
It's really interesting, especially because if we look at other jurisdictions, so New South Wales, for example, where they have the database, they do a lot of that data collection on behalf of government, and the NT's very strict. Everything goes through NT Health. Even history of working with PHN, we weren't even seeing the data from our own funded programs. So I think that is a really important piece of advocacy, and providing that transparency and honesty is probably something that we can definitely advocate more for.
Can I just two things? So we're very fortunate in Victoria, two initiatives that we run for the Victorian government. So one, what is called the Change Agent Network. So this came about in the recommissioning of the Alcohol Drug Services. So we were able to successfully apply for funding to create a network of how we build the skills and knowledge of emerging leaders. So we have a program where we have a number of nominations across the sector for people who identify as emerging leaders. We have a partnership with a leadership organisation. So what we provide is structured leadership to grow their skill sets. And so part of being part of that network is they grow their leadership skills. But the other thing that happens is they create a network, so that people agree to come together for at least 2 years. And part of that is sharing knowledge and experience around a whole range of different programs people are running. So what actually happens is a shared sort of environment where people feel safe to be able to share and discuss what's working and what's not working, and to be able to promote activities and strengthen and learn from each other in terms of what works and what doesn't. So I think that's a really great initiative, and I think supporting different services to come together, supporting sort of the growth of the next generation leaders is vitally important. So that's one initiative that I think is great, that could be advocated for the Northern Territories. So that's one. And the other thing that we're fortunate enough to be funded by the Victorian government is we run a number of community practices. So we run community practices around areas. In the past was around things like, for example, residential treatment, outpatient treatment. So just thinking about how you create, as you say, different community practices around key modalities of health delivery, and you actually have people sharing their experiences in that space and learning from each other. I think that's one of the challenges we have in the way in which services delivered and the fragmentation is there's so much good stuff that happens, but we don't get to hear about it or we don't get to share it. So creating opportunities for these communities to come together and essentially create these networks of thought leadership and practice leadership to actually be able to disseminate and learn from each other around how to successfully implement stuff in the real world, I think is really vital.
Thank you. So, Tim, my dad came to me a couple of years ago, and he said to me, "What's the deal with eggs? Are they good for me? Are they not good for me?" Like, I looked for literature, I found one paper that said they're really good, and then I've found another one, and then there was something in the news they're not good, and I need to know about eggs. Can I eat them or not? So research changes, things come in and out of favour. Dan's given us a couple of examples of other ways for people to keep up to date with the evidence. But I was wondering if maybe you could give us a bit of a researcher's insight into why do things change? Why does the state of the evidence change? What's happening there?
Tell us about eggs.
Yeah, eggs is a good one. I like that example. I think actually Anoop's presentation earlier speaks to this precisely. If everybody saw the methamphetamine trend and the change, right? So examples like that, if we don't monitor changes in trends of drugs, for example, or monitor changes in harms, how are we able to then make informed decisions? So if the trends change, obviously people's use is going to change, maybe more people smoke versus inject, etc., and therefore things are, good, bad, maybe not so much good or bad in terms of eggs, but we know a bit more about the demographics, and therefore we can make more informed targeted choices around prevention or intervention and so on. I think in terms of particular examples, a colleague of mine and I monitored trends of steroids across COVID. Again, finding that there were particular compounds, harsher compounds that people were turning to due to supply issues. More supply was happening on the dark web. More supplies were being caught, not at borders or anything, but opened instead at post, through Australia Post. And then that had other implications for them and drove, more I think the conclusions of the paper was that users turned to more health-related choices. They weren't as scared, they weren't as worried about access because they had this giant internet of things to source, I guess, compounds from. I'm assuming there's probably similar trends in other drug spaces, and by monitoring those sorts of things, like I said, we can make informed decisions about, okay, so this is what people are doing and this is what we should be worried about. So in terms of eggs, you know, might still be bad the whole time. Eggs are bad for you the whole time, but you know, we know a little bit more about who's eating them, when they're eating them, and perhaps what message we're going to give them about why. Yeah?
Thanks for working with me on the egg metaphor. We really carried that through, I think, as long as we could, so thanks for that. I want to jump back to something that I think both Dan and Chris have talked about a little bit before. So we hear about treatments or interventions, things that might have worked well elsewhere, and we want to kind of implement them here. So I want to talk about that process of adapting it to the NT. And Chris, I wondered if you had any thoughts on what kinds of things we need to do to actually scope out how it can work best in the NT context.
Well, I guess I do know that you can't just take what works in one place and put it in another. You can't just take you can get ideas and inspiration, like what's happening in Portugal, that's great. But you know, you go there, you have to understand the context within which those things work and why they work there. You can't just translate them. So we know that works with drug and alcohol, with addiction particularly. So the second part of your question was what do we do to scope that out? I think it's about a really honest look. I think that's what I keep coming back to with any evidence-based stuff. Or, you know, you've got to have a really clear-eyed look at what's going on and why people are doing what they're doing and trying to understand why they're doing what they're doing. So, and that takes a lot of thinking and a lot of effort. So even that, Dan and I were just having a quick conversation about, you know, this is when I talk to junior doctors in the hospital, and they started out with wanting to help people and you know, wanting to help Indigenous people is often sort of up there, and they can see the need, and they're there and they're in the hospital and they're working in orthopaedics, and it's the 5th time that they've replaced the same plaster on this person's leg, and they're bloody not doing it again because the person just keeps leaving the hospital and coming back, you know, in 2 or 3 weeks with it being a mess, or with they've cut it off themselves, or they've, you know, and they keep coming back and they don't understand what is going on. They fear, and they start to project anger, and these patients are very, you know, a lot of difficulty. So obviously, you know, it's not simply that these people don't want care, it's they don't want the care that you're giving them. They keep presenting for something, they're asking for something, or they wouldn't be here. But they don't want what you're offering. So you have to start from that position, and then the open and curious, well, what is it that they're after? Maybe they're after acute pain relief. Maybe they're just trying to escape from what's going on in the long grass, and that's all gets to, you know, and all they needed was actually an ambulance ride out of that situation. And they get to ED, and that solved it because they were trying to escape what was going. So anyway, a kind of an open, honest question about what the needs are, why they're there, and you've got to get the language right. So asking and people who drink collectively in the long grass and they've done it for 15 years, 20 years, the shame, the stigma, the desire for belonging. Like they just want to, they want to belong and have connection. You cannot ask someone like that to give up everyone there, give up all your friends, give up all your family, give up your only coping strategy that you've ever known. That's what you're asking them to do. It's unrealistic. So how do you get to those sort of questions? What is it that you need, you know, and get the language right? Because you can't, even the language is wrong. Do you want to stop drinking? I never get a reasonable answer. I don't get an answer to that. Of course, none of them want to stop. But I don't think, you know, maybe they're ready to try and decrease it a bit or control it in some way. Or maybe they're just so terrified of this feeling of withdrawal they can't imagine. You know, so I think we don't have the language right. So being open and being curious, getting past your own biases, that's a huge hurdle for us all. You know, I've got my own biases obviously about a whole lot of things, and so getting over those things.
It's too vague, wasn't it, that answer?
No, it's useful. I think you raise a good point that whenever we're looking at any specific kind of intervention, there's obviously potentially different challenges related to the client population here, whole different context in some ways. Dan, I wondered, do you have anything to add on that in thinking about how to scope for adapting or adapting evidence into new contexts?
Yeah, I'm just reflecting on. So I work with some amazing clinicians in multiple different settings, and everyone wants to do the right thing. And the challenge is often we're all so busy doing stuff that it's very hard to take a step back and ask the question around what we're doing, is it really working? I think that's a real challenge for us all, and giving people to the space to reflect on, we've been doing this, we're all well-intentioned, but is it really working? And I suppose it relates to the comments that Chris made before about being able to step back and look at data and be curious around what are we actually doing. So I think the biggest challenge that we often have in our service, even though our service has the fortunate position to have a whole range of researchers and educators on board, is just the busyness of our work and the fact that we're all just head down, just doing stuff. And so when somebody comes up with a great idea, that's why they don't like me going away, because I come back with ideas and want me to keep away. But, when we come back and say, look, I've heard this great thing that they're doing in the NT and I think we should explore what we're doing. I think in every context, it's about how do we get people's attention to actually step back a bit and ask the question of, what are we doing? Are we actually achieving the goals that we're setting? How do we know that? I think that's a challenge for us all in terms of working with our workforces in being able to step back and reflect. And so, I think there's amazing things going on everywhere. The challenge, I think, for us is how do we take a step back? How do we create space in our busy diaries to reflect on what we're actually doing? How do we know what we're doing is actually working or not? And then when we look at things that are happening elsewhere that's really good, how do we take a step back and think about what are the core elements of that could be really useful for our setting, and how do we apply that? I'm always reflecting, like in my career, like in the start of your career, what you're constantly chasing more complex sort of solutions to problems. And then as you become more senior in your career, you realize that actually things are about just doing simple things. And we're not very good at doing simple things. We're often trying to sort of always implement very complex things. And often we don't do the simple things well. The welcoming of people into our service, sort of just listening and hearing people, providing some very simple harm reduction sort of approaches. We're often busy trying to sort of do the latest, most complex, sophisticated things. So I think, I suppose my message is how do we take a step back out of our busy lives, reflect on what we're doing, ask the question of, are we actually, hitting the mark of what we're wanting to achieve as a service? And what are the opportunities to improve? And what are other people doing? And what can we learn from that?
Conferences are a great opportunity to kind of step back and find out what people are doing and reflect on that, like APSAD in October. Quick plug. So I'm going to take a break from my list for a second. Does anyone out here have any questions, any comments, any reflections, example of when you've tried to implement something based on evidence into your practice?
Hi, Paul Ryan. Just interested to see maybe your thoughts and reflections on how to incorporate or how well trauma-informed care approaches are being incorporated into AOD work and counselling. Particularly, does it have some sort of presence in terms of training and development of curriculums, and are there any specific successes or challenges that you can identify?
I can just make a comment perhaps up here. Look, it's a really good point, and so I think we asked that question, I think about 6 months ago, I guess, where is that trauma-informed care? And how is it integrated across the sector? So not just exactly as Dan's saying, right from the moment people walk through the door. Now, it's so obvious within my service, like the detox unit used to be a prison, looks like a prison still, you know, it's just how un-trauma-informed care could you get? It's hard to get, you know, less trauma-informed care than that particular service. And I'm amazed that, you know, people they were there as prisoners and they've come back, you know, so it's a pretty big ask. So yes, I think it's such a key issue. And so, Ingrid, I don't know if you can address this more clearly, but there is some training that we've now got access to in terms of trauma for all. The Blue Knot training, yeah, that we're trying to, that we've got funding for, we've got positions for, we're really encouraging people in our service to attend that training for exactly that. So that, because trauma-informed care is one of those classic situations that it's to be done by someone else, and it must mean, you know, complex, you know, psychological work for people with sort of PTSD, where you're doing re-exposure treatment, right? That's what it is. It's not, obviously, you know, that's one very small component of trauma-informed care, but there's all this other stuff that needs to be done that we can all do on a daily basis. And so it's one of those areas I think everyone sort of thinks it's something a bit special, a bit separate, gets siloed off. Only people with expertise are able to deliver that sort of thing, when actually really there's much more to it. And so we're trying to respond to that need. I'd say off the bat that's not done very well at the moment.
Any reflections from anyone else on trauma-informed care?
Incidentally, we've got a unit for it now as part of our new APAC accreditation. In the discipline of psychology, there's a trauma-informed care unit. Not sure if that's of any assistance though or help, but just to show, I guess, that sort of call from industry has been responded to in some ways at a tertiary level, in the hope of, you know, creating graduates that have those skills and abilities.
No, that's good to hear. The question comes from the perspective of being involved in a significant amount of recruitment of people into our social emotional wellbeing teams and councils, and we're constantly asking them if they're aware of trauma-informed approaches to care, particularly being an organisation that's focused on people. We recognise that there is a collective trauma as well as the individual trauma that people request. And so it's interesting to see when, you know, I come at it from a recruiting perspective and try to ensure that we have people who have awareness of it, and then in the AOD space, and just, you know, I was asking that question, saying, is it out there? Is it part of is it part of the thinking around, you know, the direction that the sector takes?
No, and I think that's a good example of where, you know, education should partner with industry in terms of directing course alignment with what's needed, right? It needs to be salient for not only a course as a whole, but where you're living. You know, NT obviously requires a few more specialist units as well, I think. So I think that's good to see. It'd be better if it was stronger and more linked, but only time, right?
Something to build on. Go on, Pete.
Chris made some good points. This idea that trauma-informed care is something someone else does as well is still very pervasive. I know AADANT's got a very well-established model now that they're helping organisations run through to become trauma-informed, trauma-aware. And I think in the NT as well, there's a lot of overlap with cultural safety frameworks, where there's probably a lot of efficiency that we found with, you know, trauma and cultural safety. Paul was saying there's a pretty population-wide level of trauma in a lot of the Aboriginal population, which needs to be better addressed, and organisations need to have really good awareness, especially in those entry points. You know, I think that's the bit where we sometimes fall down, and that's the bit that matters the most. You know, if someone doesn't come through your front door, then it's over, but they're not going to be engaged at all. So it is about entire staffs, entire organisations doing more than just some, you know, 2-day trauma-informed training. It's about the organisations transforming to have policy and procedures that are trauma-informed. You know, their premises have taken into account elements of things that might fall outside of the cultural safety framework or trauma-informed framework, and addressing those. But I think one of the other things that's being brought up is we're all very, very busy doing what's right in front of us, and a lot of that work is that really you need to step back and have really clear eyes on looking at your stuff and having a very honest evaluation of your service, and not being scared of saying, oh crap, we've been doing this wrong, and being willing to make changes.
I think that's the biggest barrier, actually. You know, I get very defended and very defensive about my service and my practice, and we've been doing this for 10 years. And to actually turn around and go, oh, hang on, you know, are people not entering the service? Where are our barriers to the service? It's quite hard to do. Just, you know, to say, I'm sure if it's hard for me, I'm sure it's hard for everyone else as well, to really have a clear-eyed view of something that you're invested in, you know, and that you believe in, and you're busily defending against criticism from all sort of, you know, so it is hard to do that.
Especially when you've been actively working conscientiously to try to address those things and then still be told
that's exactly right. Yeah, but I'm trying to grow up. So, you know, I
mean, it's the comment I made before about the sophistication of our sector in some way. So, you know, if you're a cancer service, you're very honest about how many people die, you know, and then you use that to advocate for better treatments, you know, that, you know, we can do better, you know, and we're very defensive around, you know, what our outcomes are, and, you know, and I think that hinders us because we don't have an honest discussion of the complexity, who does well, who doesn't do well, how we need to sort of, in some ones, nuance our treatment to different populations. We don't have a really great model of identifying different levels of complexity. So, you know, what Chris presented before around, you know, volatile substance misuse, I mean, they're people essentially with malignant carcinoma. They've got like high-end, you know, really severe levels of cancer. And, you know, it's not surprising that, you know, the outcomes are poorer. So what are we doing to step up in terms of our level of treatment to, you know, and support, you know, complexity at the social, cultural, physical, mental health level to actually address those needs? Whereas, you know, we have a very simplistic single approach, which says, oh, we take anyone, we have the same sort of approach, you know, and one of the things I constantly say to policymakers are, you know, if we were cancer services, you know, we would be offering chemotherapy. Somebody would come in, they wouldn't respond to chemotherapy, and we'd say, you know, you're not motivated, go away and come back, and when you're motivated, we'll give you the same chemotherapy again, and this time hopefully it'll work. And then they go and we're just offering the same thing. That doesn't happen in any other branch of medicine, you know. If people aren't, you know, improving, you know, it's our treatment failure in terms of we're not offering treatments that actually work rather than blaming the individual. And I think, how do we build our sophistication in terms of understanding, you know, how we segment different populations based on their need? How do we think of nuancing our response to doing that? How do we identify which cohorts do well and which do poorly? How do we advocate more strongly for different approaches for those different populations? You know, I think Peter was mentioning this before, but, you know, in Victoria, we have a number of detox services. You know, they all have different skill sets, but we're all funded to do the same thing. We're not nuanced in any way. You know, some are based in hospitals, some are based on NGOs, some are based much better at working with women, but we're all funded at the same level to provide the same outputs. There's no sophistication in the system to think how we build on particular skill sets or particular, you know, benefits, particular services in working with particular populations. So I think there's a lot more sophistication in the system we need to think about, and we need to think about ultimately how we can all be honest. So other areas of health, they have published stats around readmission rates or mortality rates. We don't do that in our sector, and I think that's a detriment to us because we don't actually see how we're performing, and we can't make arguments about how we can improve the quality of what we do and advocate for funding, you know, for particular cohorts that do badly, to say, like, we need to do better and we need to invest in looking at different approaches.
I think just on that, Dan, it's also part of the consumer group, isn't it? It's quite difficult. You can't necessarily ask somebody who's using methamphetamine and say, oh, what do you like about the service? Oh, hate all of it. It's you know, there's a nuanced feedback there, isn't there? And it's tough to present that, I think, at a research level and at a policy level.
So what we've implemented at Turning Point, we follow up people 3, 6 and 12 months following the service. So we fund it out of our research budget. and we have independent people ring up, our researchers ring up to just do outcome measures, and then also to provide some feedback about the service. And I think it's, it's hard hearing some of that. Amazingly, I think, which is really great for clinicians, the majority of people we see through our service are actually doing well. So I think it's really good, because often I think the hardest thing about being a clinician is you see somebody, then they disappear, and you're not sure if they've relapsed or what they've done. But to actually get feedback to say, oh, you saw these people, and they're actually doing well. I think that speaks, to the slide I had in my talk around our perception of recovery. We don't see, unfortunately, when people are doing well, they leave our service. They don't ring us to tell us they're doing well. And I think the more feedback we have to give us those success stories, the more that builds hope, I think, and builds our sort of self-efficacy of the workforce. But I think we need to hear what's working and what doesn't work, and so we can improve.
I mean, we often focus on the evaluation as like the end goal, like did it work or did it not work, rather than it being this cycle of how can we do better, how can we constantly improve our practice over time. And so I think I can completely understand evaluation being really scary. Like, I ran a randomized control trial of something I developed once, and it was terrifying the whole time. But at the same time, I think once you get into practices of measuring things more regularly and seeing the ways that you can feed it into what you're doing, it's sort of different perspective, Chris.
Oh, just that the overwhelming driver of the shape of the service is not evidence-based medicine. That's not the driver. The driver is there's the legislation and there's the coronial process. And up here, the coronial process is extremely adversarial, very much blame-focused, very. It's not, and when I started, and that shapes the service. There's absolutely, and when I started up here, the 20 years, it doesn't really matter what the coroner says. I mean, he can have his opinion, but really it's not law. He can make some suggestions. Sat through so many coronials now, it's harsh. It is harsh, and it's really, I can understand why our managers or my managers, they've got to respond to the coroner, and that drives so much of. We do have morbidity and mortality meetings. We do have risk and review meetings, but they're hugely driven by the coronial process, and that is not anything to do with an evidence-based service, and that is a big driver.
But we don't have that at a system level. You have that at an individual service, but we don't do it as a system. So you have your own morbidity and mortality within your service, yes, but we don't do it for the whole of NT. So we're looking at sort of, because I think the whole point of morbidity and mortality is to learn around the system and which bits of the system are working and how we can improve the system. And I think that not having that doesn't give opportunities to people to reflect on what good practice is and what isn't, and how we can improve.
It's great to have both kind of lenses on it. It's we can, I think, all feel how difficult it is working in this space, particularly hearing from you, Chris. But okay, so any other questions, comments, half-formed sentences from the audience?
I do, but if someone else.
Katie's got one.
In terms of your experience, if services don't have the time, the staff, the funding to be able to evaluate their own programs, how do they collect data themselves, and what's the most meaningful way for them to collect data to understand what they can do to change their service or to, I guess, reinforce what they're doing is working? Because a lot of our services, correct me if I'm wrong, don't have dedicated evaluation money within their budgets to evaluate any of their programs. So I'm just wondering how our services do that without the resources to do it.
I think this is where research steps in, and partnering with universities as researchers, or as good researchers should do. They step into industry and they say, hey, this is what I can do for you. And this is provided essentially for free, or on that sort of cost benefit partner together, try and work out some sort of evaluation. I mean, our strength lies in data analysis and providing theoretical frameworks and things like that. And then obviously the strength of the services in bringing in the clients, the great work that they do and continue to do, which should be this, again, cyclical process that Cass spoke about, you know, consumer advisory process. And I think that's where the partnership really thrives in terms of you have an organic partnership between a university or between a research group and an organisation, look at trends, descriptives, things like that, produce sort of reports, and that can in future provide, you know, grant funding schemes, etc., and it sort of builds from there, I think. Not to mention, you know, then we start to enter that translational evidence informing practice, informing evidence, informing practice, and so on and so forth. I think Dan would probably have heaps to add about this.
I mean, I think it's a great question. I mean, I think what you're flagging though is that, you know, we all need to be thinking about reflective practice. So none of us can provide good quality services if we're not reflecting on what we do. And I suppose the question is the level of that reflection in terms of what we're resourced to be able to provide. So at the minimum, it's about, you know, some sort of shared supervision around review of some of the cases that we have internally, how we've gone, honest reflection, either sort of with supervisors or within a team. I think it's creating that space. I think all services should be able to do that. I think it's about, you know, how we support people to do that reflective practice, and whether that's sort of internally just within the service or just partnering with other services. So we help each other in terms of, you know, providing that reflective practice. But I think we have to reflect and we have to acknowledge that this is a really tough gig we've got. You know, none of us have got all the magic right answers. And the only way that we can improve is by reflecting on what we do and learning from that. So I think that's the central premise. And then I think it's how do we set that up in a meaningful way that's feasible and sustainable. And I think, you know, that all depends on the resources of local service. And you know, and I suppose it's also, again, put another thing on Pete's shoulders, but how we create, you know, how we support reflective practice in the sector, you know, what the opportunities are, you know, where there are opportunities to partner with other organisations to support the growth in that. But, you know, I think it is about being honest with each other and sharing our learnings and sharing where we didn't go well. And, you know, I'm currently doing, for example, I'm on an essential event for something happened in another service or somebody unfortunately dies from suicide, and I'm on that panel to sort of provide advice. And it's not about blame, it's about looking at system and looking at where things can improve. So I think there's opportunities for us to help each other and to think about how we can reflect on each other's practice and help each other to grow. And I think at the minimum it's that sort of reflective practice. And then if there's opportunities to sort of more formally partner with researchers to actually look at a much more meaningful piece, I think that's a really great opportunity too.
I'll float a proposal, see if there's any agreement in the room. Most of our services get funded from multiple sources. They report to multiple sources. It's scrap reporting. Let's have services to evaluations, and they can provide one evaluation as a report to every funding body, and they can use that evaluation to better their services. Stop wasting the time with endless reporting cycles that just count numbers and don't give you any real feedback about how well your service works. Replace it with an evaluation that's done annually. That's my solution.
Pete's petition, you can sign it at the door on the way out if you're on board there.
Well, if you've got to report to 3 or 4 different funding streams, the time and resourcing required to do that, if you focus that and redirect it into one evaluation, you might come close to actually being able to afford it and afford the time. But I think we could be far more creative around that. I've seen so much pointless reporting in my life. I've done so much pointless reporting in my life. It goes somewhere. No one ever does anything with it. No one changes their practice. So there's much better ways that we can be measuring and adjusting our services that would actually fulfil the needs of what funders want and benefit services as well. Anyway, just an idea.
Just a couple of other ideas, because I think, so it's a small thing in the territory and it largely does work on connections between people, which is good and bad, we know, that Menzies is very responsive in my experience. You've got a problem, you've got something that needs research, you know that there's gold there to be had. You can float the idea with people at Menzies, and there's generally, they will find they've got, students and people who are just there who are really keen to do research, and often it can be picked up, just through those sort of connections. I know that certainly does happen. People will talk and they will say, yeah, I've got a PhD student who needs a project, I've got someone here with an interest in the area, and they've got the whole backup of Menzies for their sort of support. So that's just, if you've got a particular project, approach Menzies and see if they can help you facilitate some research. The other thing I know is it's really hard to work doggedly and persistently at something that requires a lot of effort if you've got no interest in it. It just doesn't happen. So as humans, we tend not to do that. And if you've got to sort of get evaluation data or something and you're not really that interested in it, it's hard. So spot someone within the service who loves the stats or loves the documents or loves the data collection, and you give it to them, and they will kind of then take it. And I'm looking at Ingrid, who goes, oh, I love the stats, and who really enjoys looking at computer systems and pulling out data from computer systems. So that's just another tip that I'm not going to do it because I'm just, it's too hard for me to sustain an interest in the area, but there will be someone there who might be able to. Yeah. Can't have her.
But I've got to say, we, implemented a system of clinical audits about 3 years ago in our service, and shared the load between, between registrars and nurses, and it's been it's pretty confronting, because we rotate. We have a rotation of reviewing different clinics or different parts of the service, and so it's just somebody as part of their clinical role. They're on a roster, probably once every year. They review a particular part of the service and they look at the stats and they look at the reporting. And it's, I think, because we've been doing it for quite a while now, everyone appreciates how valuable that is, because you're looking at data and saying, oh, wow, only 40% people turned up to appointments. What does that mean? What are we doing? How efficient is that? Or our mean length of bed stay is 4 days, for a certain group. Is that, are we optimizing what we're doing, or is that good that people stay 4 days or not? And so, I think it's about how, again, reflective practice and how we introduce clinical audits and make that part of standard practice. And that's a very simple way for us to constantly be just asking questions around the quality of our service and whether what improvements we can do. So that quality improvement cycle, and it doesn't cost a lot of money to do that. That's just allocating somebody a couple of hours once a month to sort of reflect on a particular part of the service.
All right, so I'm going to wrap up. Do you have an ideal vision for the future in NT of engagement between research and the practice space? And if you don't have an ideal vision, just something that you'd like to see will suffice.
Oh, I'd like this. I think what Dad does, I think it's great. So, to have a whole, so we definitely all I can really speak for is the government sort of, top end health service. But, for many years it was just me. So as the only specialist clinician here, we now have another addiction specialist. So, there's more sort of capacity and space, but definitely to have a research component to our service would be really marvellous, embedded within the service. So closer links between Menzies and us, and to have PhD students, to have the public health registrars, those sorts of clinical connections would be really, really fantastic. So that would be really great. And then I know that to then connect that to the NGO sector. I know we had a brilliant operations manager, so Sarah Gobbett was, she was able to really draw in more connections with the NGO sector. We've sort of lost a bit of that, and we've now even lost our operations manager. So, I'm not sure how that's going to go in future, but definitely, yes, there would be closer ties with NGO as well.
What about you, Tim? What are you cooking up? What's your ideal vision?
I think the other thing that I've probably forgot to mention is I've been here a very short time so far. So since the start of this year, I don't feel like I'm super well placed to have a vision. Look, they're always something cooking. Look, I think like with Menzies, CDU as well. Like Cass and I obviously are doing a few projects together and things like that. But also it'd be great to embed more, clinical masters students within actual services and programs. I think we're, at least as a discipline, moving towards specialising in more of that addiction space, considering the amount of us there that are doing that sort of stuff. And I think really want to drive that in terms of graduates that have capability and can provide, appropriate provision of services and have a knowledge of what's needed. So again, driving clinical placements and student projects is probably the other part that I'm more interested in, having projects that are partnered with industry or partnered with, actual work, not just, data in the air or systematic reviews or any of that sort of stuff, and moving that forward, giving back to industry in the same way that industry gives back to, education and things like that. I think stronger links there, but I know those sorts of things take time. I think the other thing that I wanted to draw attention to is that these things happen organically, and naturally, and it's dependent on, Pete and I got to talking, and then Cass and I got to talking, and then, I think in the NT, that's one of the beautiful parts of Darwin. I've noticed it's relationships between people, and, I think these things happen naturally when people do come together with the right vision, and I can already see things playing out quite nicely. So don't know if that's what you're after, but yeah, it's the thoughts sort of word vomit for the moment.
And then Dan, it's always nice to have an outsider's perspective. I feel like you can come in fresh, seeing how things have worked in lots of different places. So where do you see us going in the NT? What would you like to see happening?
So I think it's a great question around how we think about how do we think about bringing together research and clinical practice. I mean, I think the thing is so a few things to say. So one is that I think if you don't work in research seems quite a scary, complex beast, and I think research can be incredibly simple and incredibly complex. And I think, people get frightened of getting involved because they're expecting that's something really sophisticated and it's going to be too difficult. So I think in some ways, and this is another job for Pete, and hopefully in partnership with Menzies, and even, we'd be happy to be involved as well. But I think there needs to be some sort of research 101, for services and clinicians. Like, how do we do, like, what's the most simple thing that we can do that's classified as research that, might be clinical audits or simple data collection through to the most sophisticated, and depending on your capability or capacity as a service, how do I build up and how do I build the sophistication of what I can deliver? So I think having a research 101, a research potentially, like we in Victoria for a while, we had a research to practice network, again funded by the state government, where we brought interested parties from different agencies together who said they had an interest in research from particular organisations, brought them together, doing like a research 101 of, an introduction to research and sort of how do we do very simple, practical implementation of, research metrics from, the simple to the most sophisticated, depending on where you are in terms of capability of your service. And I think to be supported by Menzies or ourselves or whoever to sort of do that, I think, that we're trying to build up the expertise of the sector to be more sophisticated in their thinking in this space. And the question is how do we create those mechanisms to actually bring people along with us and say that research is not scary, research is actually quite exciting, and your ability to be involved in things is something that's actually very tangible. So I think that's what we have to think about. And then, once we start building up people's capability and self-efficacy in the space, it's about, where are we going together? What are the questions? Like, now we understand what we're doing. Like, what are the key questions we want to know as a broader sector? And then how can we work together? What are the simple things we could all put in place to really help us advance the field? I don't know if that's helped.
Great, thank you. Yes, Dan?
I think there was an answer there. The answer is let's set up a AOD research network and start on the basics of the 101 and then have a network of interested people who put their names down on a paper, meet on an agreed schedule of time frame, set an agenda in terms of establishing the 101 and then start building projects to put into action. I think the answer just came to that question.
Yeah, no, I agree. It's
Menzies
a really
has a thing, don't they have a training sort of program, a course you can do, a short course on introductory to research?
Yeah. I think we can maybe we can have some discussion about network meeting around whether or not that meets the needs, or whether there's something that might be more specific to AOD services that we can build from there. But absolutely.
Just volunteer to run the network meeting.
I think that was another thing on Pete's list. No, yes, definitely something to discuss for sure. So we might wrap up with a panel there. I'm sure all of our panelists would love for you to come and approach them with your ideal vision or what you'd like to see, or any other questions that you've got for them. But if we could just give them a round of applause. Thank you.